Good morning, everybody. I'm the last of the introductory speakers. My name is Peter Letsu. I'm the Dean of the Law School here, and it's really my pleasure to welcome you. On behalf of the University of Memphis and the faculty, staff, students, and administration of the Cecil C. Humphreys School of Law, thank you for joining us here this morning at our award-winning facility. And Professor McClurg mentioned we've been recognized in 2014 as the best law school facility in the United States, and I have it on good authority that we'll be recognized again on that as that. Although I'm probably breaching some magazine protocol within hopefully the next week. So it's always a pleasure to welcome you here to our law school. We have an outstanding program for you this morning, as you've already heard, and as you'll see as the day goes on. I'd like to thank once again our sponsors for their invaluable contributions to this event. I'd like to thank our speakers, obviously, for doing the heavy lifting and making this event the provocative and fascinating day it's going to be. I'd like to thank, obviously, our law review editors, or Rachel Barney especially, and George Scoville and Connor as well, for all the work they've done to make this possible. Thank Professor McClurg for his support. Again, it takes a lot of people to make a day like this, and I have to say this is just an outstanding program and a turnout like we've never seen in our law school. So to fill this auditorium and to send people to our historic courtroom for overflow, that's an amazing accomplishment, but it's a credit to the hard work that our law review and our speakers have done to make this program such a wonderful success. So with that, I would like to kick off the program this morning by introducing our first presenter, and that is Professor Michael Malinowski, who is the Ernest R. and Idris M. Eldred Professor of Law and Lawrence B. Sandoz Jr. Professor of Law at Louisiana State University, their Paul M. Hebert Law Center in Baton Rouge, where he has been teaching for almost 20 years, but he doesn't look that old at all. So I think he's only been teaching 5 years. He's the past chair of the American Bar Association's Health and Human Services Committee, and he served as a member of the ABA President's Special Committee on Bioethics. He teaches bioethics law and policy, biotechnology law and policy, comparative health law, healthcare finance and policy, regulation of food and drug products, public health law, and a health survey course as well. A former editor of the Yale Law Journal, Professor Malinowski has over 20 law review articles and journal articles to his credit. He's presented at conferences around the globe, including in Taiwan and China. His scholarly work focuses on the intersection of government, healthcare, and policy. In this spirit, he's here today to talk about the federal government's efforts to combat the opioid crisis. So please join me in welcoming Professor Michael Malinowski.
I hurt my leg, but no opioids, so I'm going to... Don't worry, there's not too many slides, it's just visuals. Alrighty, appreciation to George and Rachel for organizing this and for including me. I really do appreciate it, thank you. Alright, approximately 50 people are dying every day from opioid overdoses. Now, this didn't come up upon us overnight like the Spanish influenza outbreak, pandemic of 1918. It's been coming. Oh, sure. Should I start over? I'll repeat, 50 people are dying every day from this epidemic, from overdoses, and it's not something that came up on us suddenly. It's not like the pandemic of 1918 Spanish influenza outbreak. It's been coming for years. Oh, thank you. It's been coming for years, and we've seen it coming. So what is ground zero? I'm going to make a lot of enemies, but I mean well. Medical profession, you meant well. You and others, including patient advocates, had this epiphany in the 1990s that you were under-medicating pain, under-treating pain, so you moved in, and you started prescribing. You wanted to prescribe it away. Good intentions. Where we are now is the number of annual opioid prescriptions written in the U.S. roughly equals the number of adults in the U.S. population. 4 out of every 5 new heroin users begin with prescription opioids. And today, 40% of all U.S. opioid overdose deaths involve a prescription opioid. Pharmaceutical industry. You responded to the opportunity. It's an opportunity to benefit your shareholders and other investors, as you're obligated to do. It's your fiduciary duty, and we've gotten a lot of good out of that. We continue to get a lot of good out of that. And then some. You play up to the rules weren't good enough. Our legal and medical systems defer very heavily to the industry's communication with medical providers and direct-to-consumer marketing. As observed by Marcia Angel, former editor-in-chief of the New England Journal of Medicine, in a lot of ways, with all the marketing that's going on and with the dependence, especially in the age of overwhelming technology, you arguably have the most influential podium when it comes to medical education. According to the legal actions now being brought against you and others, and I'm going to quote the National Institute on Drug Abuse, in the late 1990s, pharmaceutical companies reassured the medical community that patients would not become addicted to prescription opioid pain relievers, and healthcare providers began to prescribe them in greater rates. This subsequently led to widespread diversion and misuse of these medications before it became clear that these medications could indeed be addictive. That's not me, that's the National Institute. That's NIDA. All right, so what has our government done to date? Actually, they've been doing a lot, and some of the agencies for quite a while. We wouldn't have the problem defined if it wasn't for CDC. Nothing justifies even a piece of 9/11, but at least we got funding to them so that they could do the work they've been doing for something like this. Without those numbers, I don't know where we'd be. Okay. And, this crisis has triggered, thanks to the numbers, a blitzkrieg of federal and state activity. There are all kinds of programs going on. Start with the federal government and looking at what's been done with the administrative branch of Congress. Well, we have a declaration. It's a national public health emergency. And we also have a commission that's been operating on opioid drug addiction, abuse crisis. They've got 60 or so proposals on the table. They're all over the place. More meaningful to me what the agencies, some of the agencies have really been trying to do. Department of Health and Human Services has already established an interagency pain research committee, trying to be very pulling in the agencies and working with others, including the medical profession and industry. The FDA gets bashed so much, and there are so many things that impede them from doing their job, which I'm briefly talk about. They've been working on this. They have a great timeline on their website, www.fda.gov. Since 2001, they stepped in. OxyContin they struggled with. They've been trying at each stage. They've been really working on getting extended release opioids into the market safely. They've been trying to do that to cut down that jolt that helps to cause addiction. They've coupled that with a program. Their risk evaluation and mitigation strategies program to try to do this safely. They've reached out to the National Academy of Medicine. They understand that they have to collaborate with the provider community. And as a matter of fact, the 3 head medical people at FDA came out, New England Journal of Medicine in 2016, with a thoughtful strategy that emphasizes that. They have to do it because it is about healthcare, but also because they cannot interfere with the practice of medicine. NIH, our epicenter here for the Human Genome Project did that so well. They've been working on a couple of big projects that you might not have heard too much about. One's a progeny of the Human Genome Project. It's the what's it called? It's the Brain Project. It's the Brain Research through Advancing Innovative Neurotechnologies Initiative. Very interdisciplinary, like the Human Genome Project, academia, industry, government all together. They also they've been working with industry and trying to solicit direct collaboration on this problem. They came out. They actually did a major event where they brought biopharmaceutical leaders together. And they worked with ANIDA, and they came out with a short-term goal of treating this, of coming up with better biopharmaceutical treatments and also alternatives to opioids, less addictive pain medication, crack that pain pathway. I'm going to have to move this along. Now, unfortunately, these efforts today just don't even come close to arising to the problem. We can't solve a problem like this by doing it piecemeal, spread across the government, even if there's good intentions, even if the agencies are skimming off their budgets and making this a priority. It's just not enough. It's not how we map the human genome. It's not how we've done other big events. This infusion of federal funding that we've been getting, 21st Century Cures Act, et cetera, the latest, the $6 billion, not targeted enough. And like the Cures Act, not funded over a long enough period of time. If you want to bring in industry and others and have a commitment to doing this, you're going to have to do it with more than that. It's just not going to be enough. And then we're dealing with people that are living this epidemic, and we are cutting Medicaid. An undeniable reality is that meeting the challenge posed by this crisis in a time frame that rises to the occasion of the crisis is going to demand that we spend tens of billions of dollars in a concentrated way. There's just no way around it. Otherwise, we're going to keep struggling. We definitely need leadership and direction that we don't have. Former FDA Commissioner Kessler, who was very active when the FDA was modernized with FDAMA in the 90s, and he has a lot of insight. And his words say, I think, they hit the point. The President's Commission has come up with 60 recommendations that are thoughtful, useful, but responsibility falls across many federal agencies that little progress is likely to result. And he also points out that the many agencies that work in this crisis live largely in their own worlds. That's the nature of what they do. They have focus. All right, on the supply side, FDA is our nation's gatekeeper for these meds and the others that are prescription meds. But they're shackled. We have a very entrenched deference to the practice of medicine. Everything that gives the FDA power shows that deference. It was repeated throughout the FDA Modernization Act process. I was part of that. It's in all kinds of testimony, and it's been adhered to by the courts. When the agency's safety and efficacy standards are met and there's a defined clinical use that's part of the whole application process, they're almost obligated to put it in the pharmacy shelves. And once the drugs get on the pharmacy shelves, in our deference to the practice of medicine, which is extreme in prescribing, off-label use is profound. And to get to that shelf, you just have to be, under our general standard, better than nothing with acceptable safety implications. Once things get there, they're used off-label. That's how we've prescribed to children without having clinical data. Up until recently, we didn't have data on a lot of our cardio drugs, but we prescribed them to women. Off-label is a big part of the whole process. And the amount that's prescribed, it's difficult to regulate for the FDA. They can put labeling, they can try to do things like education, but the fact of the matter is they cannot encroach on the practice of medicine. Education is a big part of what the FDA is hoping to push, but even with their REMS program, with that program for extended release opioids complemented, the education program has to be voluntary. They're trying to nudge it beyond that, but they have to tread carefully. They've been slammed down by the courts a number of times, shaming and suing manufacturers. Hey, I think that's a great approach to work with tobacco, but it takes time. Do we have that kind of time? I mean, I really commend the state actions. On the federal level, not so much, which I'm going to talk about in a minute. Keep in mind, though, we wouldn't have immunotherapies and we wouldn't have all the other advances we have without the model that this nation adheres to. We want our corporate interests to fulfill their fiduciary duties, to rage with that, to give them returns. We just want them to play by the rules. The rules just aren't strong enough here. That's the problem. So what do we need? How do we do something to contain this? Those trained in law are trained in the importance of precedent, and the general population has some appreciation for the fact that you learn from your mistakes and try not to repeat them and try to better things from them. Well, we have precedent in this country. We have precedent in this country for this government doing amazing things. We have overwhelming health and other issues. And we overlook that, I think. We don't step back and get it. This country, I would be speaking German if I was here at all, if I was even here at all, if it weren't for the Manhattan Project. And that was bringing together academia, industry, and government with a very targeted mission under tight time constraints, a lot of funding. Didn't go through Congress, by the way. That administration did it through shifting funds. They didn't want secrecy to be sacrificed, and they didn't want the funding jeopardized. That's maybe something like this president would do, but anyway, I don't know. I don't want to go there. But they did come in and do something that was miraculous. Hence, we walked out of that with the military-industrial complex and the whole system of grant funding science, and this government's been committed to advancing science intensely through funding since then. Move up into the 70s. Severe economic crisis. Severe. And all kinds of crises with that crisis. Everyone was sick of big government. Everyone was sick of big business because they weren't producing. We had slipped in science and technology. So what came out of that? Federal Technology Transfer Law and Policy. This grand scheme to give away invention done in academia with U.S. taxpayer dollars, give it away on the condition that it be applied. Academia, industry, government again. What did we get out of that? Called the genomics revolution. It changed everything. For some bad, but a lot of good. And the Genome Project, on the shoulders of Federal Technology Transfer Law and Policy, we mapped the human genome. A project that came in under budget, ahead of schedule, and when that thing started off, it was a white elephant. We had no enabling technology to do that. We did not have the bioinformatics. As a matter of fact, at the halfway point, we had spent a vast majority of the budget, and we didn't even have a halfway point met. It was looking bleak, but then enabling technology came along. We made, through the Human Genome Project, by putting the money up over a period of time that transcended any administration, a significant amount of money, declaring that a priority, we made that field of science an epicenter, not just for us, but for the world. And look at the returns we've got on it. The human health returns, the economic returns. Industry's made its money, but it's made contributions along the way. All right. All right, so what we need to do with all of this, we need to play off of what's worked, draw from that history. Looking at the primary objective here, advancing pain pathway science, we've got to put that in motion now because it takes time, 10, 15 years to develop a truly innovative new drug, huge failure rates, lots of money. So we need to put that in motion. Well, we've got something going on at NIH to do that. How do we bolster that, support it? I think the only way we're going to come into this and do anything that's going to actually treat and cure this epidemic is we need a congressional intervention again. We need an action that's going to move into this, give us defined leadership among the federal agencies. Yeah, they're trying to collaborate on their own, but again, it's not second nature for them. Department of Health and Human Services isn't really noted for doing such a great job with budgeting and pulling things together. Why rely on something? We don't have time for mistakes. So we need an intervention. We need it to be substantial. We need it to have enough mandates where there's administrative accountability. The agencies will do what they have to do when it's put in their face and it's an administrative responsibility to get it done. We need that Human Genome Project. We need that kind of direction. The supply side. How do we contain that? Well, I think, doing that first part, I think we could crack this disease pathway, come up with better drugs. I know we can. I've worked for the biopharmaceutical sector. They're incredible. Incredible. And they're really good now with working with their counterparts in academia and government. But we've got the drugs on the pharmacy shelves. We're not going to change physician behavior overnight. It's just not going to happen. So what do we do around all of this? And they are very profitable to produce, extremely so. And there are examples of that back up the power. You know, when you get into something like a medication that actually has treatment qualities, you got industry's voice, and they've got more lobbyists, especially now that biotech and pharmaceuticals, now biopharmaceutical, they've got more lobbyists per elected official. I've heard numbers going as high as 4. I worked for a trade organization that was a bio affiliate, trade organization national affiliate in Massachusetts. I know what it's like. I know the power that's there, and it's immense. It can be used for good, it can be used for bad, just like science itself. The fact of the matter is, though, this isn't playing out too well, hence the lawsuits, hence things like the settlement of the McKesson suit, the DEA suit, for ridiculous consequences to industry. The Ensuring Access Act, which got enacted during the middle of media coverage of this crisis, quietly got enacted. That's the power that we're talking about. When you take industry's power and you couple it with the medical profession wanting their discretion protected, we can take care of it ourselves. You know what? Haven't taken care of it yourselves. You've had that discretion. You've seen this. You were the first. You should have been the first to notice it. You were the one writing the scripts. They were your patients. You can't do this. This isn't 1940. You can't do this on your own. Your patients are coming to you and demanding. That's modern medicine. The fact of the matter is you take organized patient advocacy groups like the oncology groups, and you couple them with industry, and you couple them with providers, and again, we need to do something that trumps that. Everyone will play by the rules, and they will thrive. But if we don't have the rules, then we have this. That's what got us here. All right. By giving a mandate from Congress, you're going to elevate the FDA's authority. I'm not saying that we're going, I think it should be really focused. We have to focus on this crisis. Discretion to prescribe, another day. Let's do it piece by piece. This is a big piece. Let's just focus on this. And if you can't get the medical profession to acknowledge that they can't do this on their own, they haven't done it on their own. States regulate the medical profession to a large degree. Addicts travel, pills travel. So we can't rely on the old mechanism. We need this kind of an intervention. So the scheme setup that I'm proposing, provisions, I've got an article coming out with George and Rachel that spells all out and really trying to skim the surface here. Any federal government interaction has to reach to the state. That's the soil where this is playing out. And states have been some of them have been so innovative and come up with it with no money. In Buffalo, New York, Stafford County, New Hampshire, the drug court mechanism to, prosecution, but couple that with treatment and try to actually deal with the healthcare reality of the issue. Regional medical centers like East Texas Children's Hospital, they've established an intensive care unit to treat neonatal abstinence syndrome, which is withdrawal from all of this. We need that stuff funded. Where it works, we need to specifically say we'll fund it. And where it's exploratory, then we need to put funding, maybe federal, state matching funds to get that stuff to continue to go forward, to try it. All right. So, to wrap this up, at times, what seems impossible does happen. I got to do a St. Jude visit yesterday. I won't put that on. We have to remind ourselves of that. And I go back to Manhattan Project, the Human Genome Project. We've got examples. The whole industry we have today. In the time it takes to develop a single innovative drug, 10 or so years, we developed a whole industry. We made the bureaucratic established pharmaceutical sector wake up and embrace the new science. That's like changing a country. So where do we stand with all of this? Okay, my proposal does call for substantial government intervention, but the opioid epidemic is overwhelming, and nothing else is going to rise to the occasion of actually treating and curing, containing. I don't know how you feel about it, but the declaration, public health emergency, not state of emergency that would have got automatic funding, and the delays in coming up with tangibles. As far as I'm concerned, fully acknowledging this epidemic without commensurate action, which means writing a check, which, it's blasphemy to say, but I'm sorry, without regulation. Everything that's been done constructively since I've been working in this field, industry-wise, has been done on the shoulders of regulation. You don't work in a vacuum. You need rules to play by. I tell my students all the time, you wouldn't go to an LSU football game unless you're really sick if it was no rules and regulations. That's called the Coliseum. To come out and declare this a public health emergency and not back it up, and for Congress not to be acting, I know so much divisiveness, but get your act together. It's happening in your soil, in your districts. Wake up. To do that, to me, is the cruelest, hollowest form of hypocrisy. We can do it. We know what we have to do. It's a lot, but it's focused. We have precedent for it. Time to act. My time is up, and what I'm going to point out to you is during that 30 minutes or so I was here, at least 2 people died of an opioid overdose in this country. Thank you.